All right, so welcome to week 16 of our neuropsychiatry didactic series. We're going to be talking about addiction, which is a great segue from our earlier psychosis lecture, and also connects to our next two lectures, the first one on anxiety and the next one on depression. This lecture is going to be mostly related to the work of Nora Volkow and George Koob, and their kind of integrative framework of understanding addiction through a brain first basis. Um, these are our learning objectives. You can see this in your own time. And then here we're going to be discussing some of the history. And so, for most of human history, we've been using substances. However, this use has been seen more through moral, religious, and cultural lenses. Um, Often seeing excess use as a failure of character or willpower or virtue, or framed as sinful or criminal. And although a lot of those, sentiments still unfortunately exist today, it wasn't until the 20th century or so that we started seeing things from a more biological lens. So starting around 1954, James Olds and Peter Milner found that rats that had a specific placement of electrodes when that could be stimulated if they were to press a lever, would repeatedly press this lever over and over again. We see the rats here on the bottom left. And the area that these electrodes were in what we know now is the mesolimbic dopamine system. And this led to the finding that motivation and reinforcement were localized to these neural circuits. And then by around the 70s or so, dopamine became increasingly associated as a possible like pleasure chemical, and then there's new studies using EEG that started to challenge this and led dopamine to be seen more as being associated and influencing behavior rather than pleasure based on specific dopamine firing patterns. And then by the 80s or 90s, there were some animal studies that were done by Kent Berridge, who then collaborated with somebody named Terry Robinson by 93, that solidified the idea that dopamine is actually more associated with motivation than it is pleasure. And so by 93, they published this paper together called The Incentive Sensitization Theory of Addiction, which claimed that repeated drug use sensitizes dopamine systems, which lead to an enhancing incentive salience of drug-related cues, and which we're going to talk about later on in this talk. That kind of helps reframe addiction as a pathology of motivational learning. And so, since this time, dopamine has been seen more as a neurotransmitter involved in learning, prediction, and motivation, rather than just hedonic pleasure. And then with the advent of functional imaging studies, by the 1990s, work by Nora Volkow and her colleagues demonstrated that people with substance use disorders tend to have reduced dopamine D2 receptor availability in their striatum, which was a finding that was replicated across studies using many drugs, alcohol, cocaine, methamphetamine, and opioid use. And this finding, they also found that those impaired prefrontal cortical activity, and these functional imaging studies, and this helped link addiction to deficits in executive control, decision making, and self-regulation. And this went on to show that chronic drug use can lead to blunted responsiveness to natural rewards, and sensitizes the brain to drug-associated cues. And then in parallel, around the same time, George Koob showed that addiction isn't really just about reward, but it's also about the progressive recruitment of stress-related systems, which led him to coin the idea of an anti-reward system, which helps explain why addiction can go on even when drugs aren't really producing pleasure anymore. And so by the early 2000s, all these lines of research converged into the modern three-stage model of addiction, which is the basis of this talk. And yeah, we'll talk more as we go forward. For now, from a cultural perspective, historically, many different cultures have integrated psychoactive substances into their own ritualized and socially regulated frameworks. This can include, alcohol, cannabis, stimulants, and psychedelics, which have all been embedded in communal ceremonies, rites of passage, religious rituals, and healing practices. So, in these contexts, substance use has been bounded by meaning, structure, and collective oversight, which has likely helped constrain excessive use and maladaptive learning. Um, and in stark contrast, in the West and modern industrialized societies, uh, this is the use of substances has been basically gradually decoupled from ritual and meaning, and then commercialized and optimized for potency, speed of delivery, and frequency of use, which has led a lot of these to, of course, become very addictive. And as we're likely all familiar with, there was a cultural revolution that took place in the 60s that was largely propelled by psychedelics, which we'll cover on a future lecture. But this unfortunately became entangled with the Vietnam War and politics at the time, and ultimately led to Richard Nixon declaring a war on drugs, leading up to the Controlled Substance Act of 1970 and the creation of the DEA in 1973. This was unfortunate because the criminalization of drugs in the U.S. Further perpetuated addiction, leading it to be seen more as a moral failure and a threat to public order. And not only this, but this has also led to innumerable tragedies like, social marginalization, mass incarceration based on race, racial discrimination, systemic dismantling of families, exacerbating trauma, worsening poverty, chronic stress, just to name a few. And so these politically driven views of substance use has largely overshadowed the average person seeing addiction as a neurobiological process. And in replacing that more with this just sort of stigma that doesn't seem to be very helpful. And this kind of political angst has also limited the potential to fund research to better understand these substances so we can pave the way for more evidence-based legislation and drug reform. Talking a little more about the stigma specifically, perpetuating this in our society is that paradoxically likely worsened addiction by increasing stress, shame, and social isolation, which we'll learn in this lecture, are actually risk factors for worsening addiction. And cross-cultural research has also shown that social cohesion and meaning making acts as protective factors against addiction. So communities with strong interpersonal bonds, a shared identity, and collective responsibility may actually buffer against chronic stress and reduce reliance on substances for emotional regulation. It's also interesting to connect this social cohesion to what happens in AA meetings and how longstanding attendants have said that the socialization is actually and that support is one of the most helpful aspects of AA. And this is also relevant when we look at emerging addiction treatments and psychedelic assisted psychotherapy. Which we'll talk about a little bit later here. But when we look back and learn from indigenous and ceremonial use of psychedelics, and how they emphasize preparation, intention, guiding, and integration as an essential holding environment for therapy for substances, we found that it's been pretty essential for the therapeutic aspect of it. And then from another note, there's also public health oriented frameworks that implement more harm reduction approaches, which implicitly acknowledge that addiction is a disorder of brain and behavior rather than morality. And so there's a push more to emphasize safety and reduce harm, along with also reducing stress and marginalization along the way as well here too. So as you see, culture is exceptionally important for us to better understand addiction, and especially when it comes to understanding it within somebody's particular social context. And that's something that neurobiology alone can't do. All right, so here, I'm not going to go through all this, but this is basically the entire DSM screenshotted in terms of substance use things. And for the sake of time, instead of going through each criteria, I think it would just be more helpful to see what all of these criteria have in common. So some common features is that just about every use disorder can be further classified in terms of severity, so mild, moderate, or severe. And each diagnostic category can be broken into four subcategories, which we'll go in a little more detail, but just to cover what they are, there'll be impaired control, social impairment, risky use, and aspects of pharmacology. So there's a set of symptoms within these subcategories, and if patients have at least two of these symptoms that we'll go through over the past 12 months, that's enough to label them with a substance use disorder, which is why we probably see a lot of patients in the hospital with charted, substance or polysubstance use disorder, which is really, really hard to get removed. So for the first subcategory here, which is impaired control, the DSM-5 requires that the patient is taking larger amounts of the drug, having unsuccessful efforts to cut down, and or craving. And so neurobiologically, this likely alludes to impaired top-down inhibitory control from aberrant dopamine signaling. And subcategory number two, social impairment. This is exhibited by interpersonal problems related to use, functional impairment, withdrawal from activities, and neurobiologically, this is likely related to progressive narrowing of motivational salience. Number three, risky use. This involves using in hazardous situations, not having much regard over potential harm. And it's likely due to, yeah, at least psychologically, to evaluation system being skewed towards immediate reward. And then finally, in terms of pharmacological aspects, this involves symptoms of developing tolerance and withdrawal, with tolerance reflecting receptor level adaptations and withdrawal engaging the activation of this anti-reward system, which we'll eventually discuss. All right, so functional neuroanatomy. This is probably the most important slide. So we'll talk about this slide just as an overall view of Cobol's, of Kubin and Cobol's and Volkoff's three-stage model. So the first, the reason that this is the centerpiece of this talk is that it basically integrates all the relevant neuroanatomy into a neat package, so we can functionally understand the neurobiology of addiction. And I know there's three steps here, but they're not technically, sequentially like this linearly all the time. It's a cyclical process. It could be even a self-reinforcing loop. So there's no clear beginning and end, but this is as close to a beginning and end as we can get. And so starting with stage one, this is binge and intoxication. This stage is mediated by the reward system, and it's defined by early reward and habit formation. And so the reward system is, of course, the mesolimbic dopamine system. And especially, it's composed of the ventral tegmental area, which is the VTA, and its projection to the striatum and nucleus accumbens. Um, Acute substance use would lead to a phasic dopamine spike, which reinforces stimulus response learning and strengthens connections to cues associated with the reward, which is the drug in this sense. And so basically in this stage, substances are taken for positive reinforcement, which characterizes what the use is. And we'll see how that use progresses over time. So by the time we get to stage two, this is withdrawal and negative affect. This stage is defined by the anti-reward system. So while the first stage was the reward system, the second stage is the anti-reward system. And this is the defining characteristic of this stage is the start of anxious distress. And that's the anti-reward system, which we'll talk about in more detail. And it involves the extended amygdala, the lateral habenula, and basically leads to a lot of these stress-mediated neurotransmitters, and eventually decreases basal dopaminergic tone, leading to anxiety, irritability, apathy associated with drug use. And so, another characteristic of this stage is that while if stage one, the reinforcing reason to use drugs is the positive reinforcement of the reward, in stage two, it's actually the driving reason to do it is actually a negative reinforcement of the anti-reward, meaning that they do the drug so they don't, not because they feel good, but because they don't want to feel bad. And then by stage three, this is more of a cortical stage. This is called, stage three, preoccupation and anticipation. And so this stage is defined by progressive impairment of prefrontal cortical control. And so, of course, the frontal lobe usually regulates our impulses, evaluates consequences, and inhibits maladaptive behaviors, and all of this is less likely to happen around this stage. And so we essentially see a functional hypofrontality, or for like in neurological terms, a functional frontal lobe syndrome, which we'll talk in more depth in its own slide. But basically, with the loss of this top-down control, then this powerful affect, this dopamine release that happens when people are exposed with drug use cues. This leads to behavior that can't be inhibited, heightened cravings, and lack of insight, and inability to suppress the response to the triggers, leading to almost compulsive drug use. And so we'll have a slide on each stage of this model, but we're just going to do a quick segue to talk about psychosis. So in connection to our last lecture, it's always important to think of psychosis as primary or secondary. And for the sake of this lecture, if it's secondary, we're thinking, is this substance induced? Specifically, secondary to stimulants like cocaine, meth, or high dose amphetamines, which can all lead to, of course, high dopamine states in the mesolimbic system, and could lead to the same aberrant salience model that we see in psychosis and possibly even mania. Which we actually see quite frequently. So whenever a patient with substance abuse history comes in psychotic and manic in the CPEP, it's really hard to differentiate between primary versus secondary causes of psychosis, especially when they have had similar presentations in the past, which is why so many of them get diagnosed with schizoaffective disorder. And in my opinion, on the subject of stigma, um, our greatest weapon is understanding the science behind things, and recognizing that it's not really a moral or volitional a failure of somebody to use. And when we call somebody maybe schizoaffective, that might also have its own implications. And so maybe with maybe by understanding this pathophysiology, we can also lessen the risk of sloppily labeling somebody as schizoaffective, and rather understand the underlying aberrant salience, or whatever the biological model is that's leading them to have the behavior that they're having in front of us. So let's go back to the Kuban-Volkows three-stage model. Let's talk about the mesolimbic reward circuits, which of course is the first is the first stage of their model. So the reward system is involved in motivation, reinforcement, and incentive salience. It shares a lot of the same anatomy of a lot of other things that are really important, such as the salience network, and also Jack Panksepp's seeking system, which we'll talk about a little later on in this lecture as well. Um, to start off with, the first important node of the mesolimbic system is the ventral tegmental area, or VTA. It's found in the midbrain. It has all these dopaminergic neurons that project out to limbic and cortical targets. Excuse me. And these dopamine neurons act as sort of teaching signals by encoding specific discrepancies between expected and actual outcomes, which are known as prediction errors. And drugs of abuse tend to hijack this learning signal. So the VTA itself is regulated by all kinds of different neurotransmitters. Local interneurons inhibit it through GABA. There's some excitatory inputs from the prefrontal cortex, amygdala, and hippocampus, which release glutamate. There's also a lot of modulation from opioids, endocannabinoids, and serotonin. And most addictions have affect the circuit in some way. And so some examples of that is that opioids inhibit GABA interneurons, which then leads to disinhibition of dopamine neurons. Alcohol modulates GABA and NMDA receptors. And nicotine directly excites dopamine neurons. And while cocaine blocks dopamine reuptake, leading it to kind of accumulate over time. And this explains why vastly different drugs can all lead to similar reinforcement patterns. Um, and so we're still at the VTA here. Dopamine from the VTA projects out to the nucleus accumbens predominantly. That nucleus accumbens is actually divided anatomically into two parts. There's the shell, the outer part, which is involved in emotional salience, and then there's the inner part called the core, which is involved in action selection and cue-driven behavior. So dopamine in the nucleus accumbens assigns motivational value to certain stimuli, and it strengthens the associations between cues and certain actions, along with also biasing future behavior towards acquisition of reward. And so from the nucleus accumbens, there's the final projection here in in the lower brain areas, which go to the ventral pallidum. And so this is the final common output for limbic motivation. The ventral pallidum integrates signals from the nucleus accumbens and translates them into motor readiness and behavioral engagement. And so in addiction, there's pathological signaling from this area projecting out from this area that becomes biased towards drug-seeking behaviors. And so all this projects out towards the prefrontal cortex by shooting dopamine at it. But also the PFC prefrontal cortex also communicates back to the striatum by sending glutamate. And so that's kind of how they talk to each other. And there's obviously different parts of the prefrontal cortex that are really important, like the orbital frontal cortex, the ventromedial, and dorsolateral PFC, along with the anterior cingulate. And we're going to talk about them in more detail in their own dedicated slide. But the overall goal of the prefrontal cortex is to try to decode these dopamine signals and learn, basically. Um, so, um, we talked about these neurotransmitters, dopamine, glutamate, GABA. We talk about salience, attribution, and how dopamine is a prediction, error or signal. So just to review all this in cognitive neuroscience terms, normally dopamine spikes occur in response to unexpected rewards or surprise. And learning stabilizes once these rewards start to become predictable. And so motivation to act remains flexible and context sensitive, normally in this kind of, balanced feedback loop. But in addiction, drugs produce, a super high dopamine signal that distorts the prediction error signal. And so learning becomes biased towards these hyper salient drug cues, even when the outcomes are harmful. And so this is really important and actually ties into our next slide on learning and incentive salience, which is sort of used synonymously. Um, so incentive salience is important to know about. It's basically, the modern understanding of how dopamine encodes motivational significance, and leads to how much basically a stimulus is going to grab your attention and energize you to act. And so dopamine, even though historically it was seen as a pleasure molecule, which is a sort of a misnomer. If we were to accept this, I think two words that might make more sense if we were to subdivide it in a way that might make more sense is instead of pleasure, maybe dopamine can actually encode whether we like or want something. But just because those two things have different circuits. So when we like something, we're just receiving a signal that some kind of experience is pleasurable. And so this is mediated usually by endogenous opioid and endocannabinoid stimulation that goes to the nucleus accumbens and ventral pallidum, which we talked about. Um, and so to contrast this with when we sort of want something, this usually refers to a motivational drive of some sort. So we're trying to get something, and that's usually behavior that's motivated by dopamine signaling, and this would be in mesolimbic circuits as well. So both of these processes are overlap in early substance use and just normal behavior. But as addiction progresses, they gradually decouple. And so it gets to the point of pleasure actually, or the liking decreasing while the wanting escalates. And this is due, the liking decreases because of tolerance, while the wanting escalates because of sensitization of motivational circuits. Um, and so that is basically what happens. Now, because of this sort of learning that's going on, and because of this incentive salience, neutral stimuli, start to become conditioned to be associated with the drug use. And so these could be like locations, people, emotions, or times of day even. And so it gets to the point that exposure to the cues alone can elicit a dopamine release and arousal that invokes a certain behavioral drive. And so a craving and maybe even an action can happen without even conscious desire or pleasure preceding this. And over time, this incentive salience, this motivation to act, can actually intensify. Behaviors will become less flexible and responses become increasingly bound to their stimuli. And so actions eventually start to become compulsive and lacking reflection. And again, from a predictive coding perspective, addiction occurs due to overweighing of predictive signals and underweighing of evaluations about the outcome. And this is all due to pathologically over precise priors about the reward. So keeping this entire process in mind, it helps shed light on a lot of behaviors that we see in addiction. Specifically, why insight alone isn't typically enough to stop addiction, and why relapses can happen even after years of abstinence. Why stress amplifies the craving. and it reframes this whole process as biology rather than a moral failure or weakness, like we talked about before. So for the second stage of the model here, this is when the anti-reward system kicks in, which we'll talk about in just a little bit. And just as a reminder, remember in the first stage, early addiction was driven by positive reinforcement. Now, later addiction is being driven by negative reinforcement. And so, by this stage, addiction is sustained a lot less by chasing the reward and rather just trying to avoid stress related with not having the reward. And so, that's why George Koob thought that this was more of like an anti-reward system that was going on. Um, and so, how do you explain this emotional pain, uh, I guess, neuroanatomically? Well, there's certain components of the anti-reward system. I actually forgot to mention one here, but the components are the central nucleus of the amygdala, which I'll just say the CEA from now on, and the bed nucleus of the stria terminalis, which I'll just say BNST. The BNST is going to be really important in our next lecture on anxiety. And the part that I forgot to mention, because it's sort of far from this, is called the habenula, specifically the lateral nucleus of the habenula, which is in the epithalamus, just around the pineal gland, which is also involved in the feeling of negative states. And so to talk about how all of these are sort of related, um, you know, when the when there's a chronic use of you have all this dopamine over time and this incentive salience that we talked about. Eventually, the BNST actually gets activated and releases these stress neuromodulators like CRF, dynorphin, and norepinephrine. And this in itself leads to hyperarousal, anxiety, irritability, and overall emotional pain. In the normal state, this part of the amygdala, the CEA, normally inhibits the lateral habenula using GABA. But in the stressed out state, when the BNST is releasing enough CRF into the system, it eventually actually stimulates the lateral habenula. Now, the lateral habenula is normally inhibited, and so it normally doesn't work. But when it's disinhibited, it actually acts to release glutamate to the rostromedial tegmental nucleus, which releases GABA to the ventral tegmental area. And that GABA actually inhibits the VTA from releasing dopamine. And so basically, what the function of the lateral habenula is actually to inhibit the reward system, hence the name, the anti-reward system. And so when we are basically not using drugs, um, we get this we start to feel stress, and that actually releases these stress chemicals that eventually actually lead to the stopping of our dopamine, and we feel even worse. And now we're desperate to get some dopamine back, which leads to this vicious cycle. And so basically, the brain becomes chronically sensitized to this stress. And because of this, the brain gradually shifts to this new baseline of just feeling dysphoric and anxious just about all the time, with higher thresholds to feeling pleasure and more likely just feeling apathetic. And this kind of resembles the phenotype of melancholic depression and severe anxiety states, which also likely explains this high comorbidity between substance use disorders and mood disorders. Okay, so in terms of the prefrontal cortex, this is what I promised we would talk about. So this is the third stage of Kuban-Volkohl's three-stage model. It's defined by cortically driven preoccupation, which is sort of similar to the obsessions of OCD, and dopamine-driven anticipation. And this stage, was basically found through a lot of functional imaging studies that Volkol and Koob did, which showed general hypofunctioning and key areas of the PFC. So it's more helpful to cover what those areas are. So starting with the orbital frontal cortex, this is the part of the brain that normally functions to compute relative values from dopaminergic input. And now in addiction states, it actually overvalues substance-related rewards and undervalues consequences in the future related to that. And so this leads to a distorted computation of values. Next, we have the ventromedial prefrontal cortex. Normally, this works to integrate emotion and decision making, and in addiction states, this leads to impulsive decision making with new deficits in anticipation of guilt or fear. Now, the anterior cingulate cortex, normally it works as a sort of conflict monitor for competing signals that may arise, and now it just receives aberrant signals, making it really difficult to learn from mistakes. And finally, the dorsolateral prefrontal cortex, which normally functions to maintain attention, working memory, and exert top-down control. In addiction states, when this is hypoactive, it leads to an impaired ability to hold long-term goals in mind, and also leads to a difficulty in suppressing habitual responses. So overall, what we see is this functional hypofrontality, which is a defining feature of chronic addiction. And also leads to, a lot of failure in terms of the normal ability of the cortex to suppress demands from the lower brainstem. And so those incentive salient signals that we talked about that are coming from the striatum and the stress signals from the extended amygdala are felt even more now. And so clinically, what does this mean? It sheds light on why, insight isn't usually enough to really curb addiction, like we've talked about before. And even if you have the intellectual motivation, to change, it might not be enough to override those really strong signals coming from the lower parts of the brain. And this is why people with chronic addiction, can look like they almost have a dysexecutive syndrome. So these are just, just first to go briefly on some of these different chemical states. Chronic addiction, we see downregulation of D2 receptor density in dopaminergic signaling in the nucleus accumbens and dorsal striatum, meaning that normal rewards are going to lose their motivational impact, which can eventually lead to apathy, as we've discussed. Stress systems from stage two which lead to increased CRF and dynorphin. This leads to dysphoria and more reactivity from stress. But paradoxically, actually releases more dopamine associated with drug use. Um, and there's an association between low D2 levels and impaired metabolism in the prefrontal cortex, which leads to a loss of this executive control that we talked about in the previous slide. And over time, there's a progressive shift from ventral to dorsal striatal control, which means that the goal-directed and reward-driven behavior in early addiction, which is dominated predominantly by the ventral striatum, becomes habitual and compulsive, which is something that's more mediated by the dorsal striatum. And so this might, in part explain why behaviors in people with substance use disorders can feel automatic and outside of their conscious control. All right. So this is the last quick segue. I think it's really interesting, but we'll have a whole lecture on this. But there's something called affective neuroscience, which was mostly founded by Jack Panksepp, and it focuses on basically having all our emotions explained by these seven primary emotional systems, which are all in all caps and listed here, like seeking, rage, fear, lust, care, panic, grief, play. And like we've sort of mentioned earlier, there's some overlap between the reward system, the salient network, Salience Network, and the Seeking system. And so this Seeking system is just like a rebranded version of the reward system. And it's also associated with anticipation, but Jack Panksepp uses more like biological evolutionary terms and has also made associations of the system with curiosity and exploration. Um, and so Jack Panksepp has called dopamine as not really a pleasure molecule, but more as a foraging system, neurochemical, which evolutionarily motivated us to engage with the world. And so this is sort of overlaps with the idea of incentive salience. Panksepp also had really interesting views of addiction. He thought of addiction as a switch from the seeking system normally interacting with other circuits, namely care and play, and becoming hyper-focused and rigid. And so that leads to the blunting of care and play. And this would explain the social withdrawal, loss of interest, and emotional flattening. And then Panksepp also emphasized that the panic grief system was calmed by opioids, and there's some thought that early disrupted attachment and development actually leads to a hyperactive panic grief system. And so that might in part explain why some people are motivated to use opioids specifically to try to calm that down and kind of self-medicate. And so, I just thought that this was like an interesting alternative and complementary perspective to Volkol and Koob, because this really emphasizes more the subjective experience. It emphasizes development, it emphasizes relationships and early attachment. And we do clinically see this. This sort of disrupted attachment is a very common theme and risk factor preceding substance use. So just wanted to mention that here before we start talking about clinical stuff. So, the rest of this, it's going to be a lot of the things that we've kind of discussed before in terms of workup. We always start with a history, specifically when it comes to the stages that we talked about. It's kind of good to ask yourself where you think the patient is. Are they in like the reward, stress, or loss of control kind of parts of the stages? And so some questions that could be good to ask is just their pattern of use. Well, first off, like what do they use? And then pattern of use, and if that use is escalating, if they're going through periods of binging or feel loss of control around their use, ask about their triggers. So external cues, but also, if stress and emotional states are cues too, and their own motivations to use. Are they seeking pleasure or relief? And have they had periods of abstinence before? How did that look like, and why did they did relapse happen? Collateral is extremely important to get for these patients, since having that third person perspective kind of helps compensate for possible impaired insight and self-monitoring that they may have, especially if they've reached the stage of experiencing the executive dysfunction, stage three. We have certain screening tools that we can use, like Audit, DAST, Cage, and Assist. I personally haven't used them much, so I can't really speak on it much. But more commonly, when a patient is just coming into the ED and altered, and we're not sure why, we just about always send out a urine drug screen, which could be really helpful. There's a 10 drug toxicology screen, or we can use 5 drug and then just add additional studies to it to ensure everything gets collected, like amphetamines, THC, PCP, and blood alcohol level as well. Um, if we think that it's like late alcohol use, like it's been a while, maybe PEth, And then also we can check their LFTs, GGT, and also any kind of comorbid infectious diseases like HIV, hepatitis, which is super common, especially if there's an IV drug user. Um, Keeping in mind too that certain lab abnormalities can lag behind any neural dysfunction. So a normal lab panel doesn't really imply like how severe their disorder is. And aside from the medical piece, it's arguably maybe even more important, depending on the case, to screen for primary psychiatric comorbidities, which can often lead to treatment implications as well, and kind of secondarily help with their substance use. So, such as, they might have sensitivity to stress and reward and mood disorder. Maybe there's a relapse risk in the context of stress in somebody with anxiety, or they might have some reactivity to certain cues in PTSD. And so, maybe there's even a baseline vulnerability in their own executive function if they have ADHD, and they might just be unknowingly trying to self-medicate with stimulants. And so, knowing their primary psych history helps to know, what their vulnerabilities are and how we can help them as well. In terms of neuroimaging, we don't often get it unless there's something else going on. I mean, I guess theoretically, if they really look like they have a frontal lobe syndrome, we might want to get one. But also, people who use substances often get hurt and are at greater risk of getting like TBIs. And so, if there's any concern for like head strike or prior trauma, then getting imaging could be helpful. But putting all of this together, I wrote, a very neuropsychiatric formulation here, just so we can have an idea of how this could look like. And so I quote, we can say that a certain patient has severe alcohol use disorder, which is driven primarily by stress-related negative reinforcement and executive dysfunction, aka stages 2 and 3, with secondary reward hypofunction and comorbid PTSD, which gives us an idea that they're probably hypervigilant and reactive to cues, and maybe talking about getting some trauma-focused psychotherapy. If they're able to follow up outpatient, might actually help with their alcohol use disorder as well. And so this vocabulary helps, improve prognostication, target treatment, reduce moralization and frustration, and better align with the patient's current biological reality without our preconceived notions. And here there's quite a lot of different medications that we can use. These are in addition to therapy and not a replacement for therapy. So that's really important. And we'll talk about therapy on the next slide. But all of these drugs modulate one of the systems that we talked about in some kind of way. So starting with naltrexone, this is a mu opioid agonist and kappa antagonist. It reduces alcohol and opioid related rewards. And it does this by blunting cue-induced dopamine release in the nucleus accumbens. Buprenorphine, this is a partial mu agonist and kappa antagonist. It's thought to stabilize opioid tone, and so it leads to reducing withdrawal, craving, and stress-induced relapse from opioid use. From Coop's framework, this doesn't just work on reward, but also might work on anti-reward systems. And then methadone is a full mu agonist and works as a kind of substitution therapy to prevent withdrawal and reduce use. Bupropion is really an antidepressant, atypical dopamine norepinephrine reuptake inhibitor. It modulates dopamine, and it's actually been found to be pretty useful for nicotine use disorder. While varenicline is a replacement, for nicotine by being a partial nicotinic receptor agonist. It works by reducing phasic dopamine, and so it reduces nicotine-induced dopamine spikes, and prevents the withdrawal and nicotine use disorder. And so the charts on the top right here. These, focus more on dampening the stress and anti-reward systems. But acamprosate is predominantly like a modulator between glutamate and GABA, and it reduces withdrawal and stress reactivity. And we use that for alcohol use disorder. Gabapentin kind of works similarly, actually. Usually in higher doses than we typically prescribe gabapentin, like usually like around 600 TID or so. And it dampens, stress circuits, like we said before, and helps with reduce relapse risk in alcohol use disorder. Um, these two alpha-2 adrenergic agonists like clonidine and lofexidine, they help reduce noradrenergic hyperarousal. So this could be helpful in controlling the negative feelings associated with the withdrawal and stress-induced cravings as well. This third chart is just kind of like a miscellaneous pile, but in acetylcysteine, I wasn't really sure where to put it. But it's a precursor to glutathione, and it helps restore glutamate homeostasis in the circuits between the striatum and the prefrontal cortex. I'm not really sure how that works, but it's thought to reduce cue-induced cravings in some disorders. And then topiramate is also another odd one, but it's supposed to restore GABA and glutamate balance and help impulsivity, and it's used off-label for alcohol use disorder. While disulfiram is really hard to use, but it inhibits aldehyde dehydrogenase, and it just makes you feel miserable if you drink alcohol. But you have to remember to take it and be a very compliant patient. So in terms of psychotherapy, motivational interviewing is usually first line. It basically just fosters a collaborative, non-confrontational partnership. It allows patients to articulate their own intrinsic motivations to quit, and this is all with the goal of enhancing their own reflective capacity and building rapport along their journey to quit. It's usually a pretty good first step to kind of empower the patient through their journey, and make them feel empowered rather than feel forced into it. CBT for addiction works to identify and restructure these cue response patterns and strengthen top-down inhibitory control. And it targets this conditioned incentive salience by teaching patients to anticipate triggers and plan accordingly by using kind of alternative responses rather than their own automatic habitual responses. Contingency management is probably underused, but apparently very helpful. It uses, specific tangible rewards, like vouchers, prizes, or cash to compete with drug reinforcement. These rewards are typically conditional for like specific target behaviors, like if whenever you get a negative drug test, or you're attending treatment sessions, or adhering to medications. And yeah, it's pretty helpful. And then finally, there's mindfulness-based relapse prevention, which uses mindfulness and meditation to enhance insight, so you can kind of feel the craving as a transient internal state rather than a commitment to act, and sort of accept it as it is. The goal of this is to help with this interoceptive awareness and reduce these automatic craving responses to weaken these compulsivity loops. And then there's other things that aren't really psychotherapies, but they're more socialization-based interventions, but that are really, really helpful for a lot of people, such as Alcoholic Anonymous and Narcotics Anonymous. And, how much time do we have? So, because we're almost done, there's a really interesting backstory to Alcoholics Anonymous. So I just want to take a quick side tangent. So and it's about Bill Wilson, who was one of the co-founders of Alcoholics Anonymous. So back in the day, like in the early 1900s, there was a hospital on the west side of Central Park called Towns Hospital. And there's a Dr. Alexander Lambert, who was actually Teddy Roosevelt's personal doctor, who came up with his own personal cure against addiction, which he experimented on patients at Bellevue. who had alcohol use disorder. And so this cure was actually a concoction with like a lot of weird stuff. Like it had belladonna and barbiturates and I don't even know what else. And anyways, one of his patients was actually Bill Wilson, the co-founder of AA, and it was in 1934. And this concoction actually led Bill Wilson to have a mystical experience that led him to never drink again and eventually go on to co-found Alcoholics Anonymous. And then by the 50s, Bill actually started to experiment with LSD under the supervision of psychiatrists in LA to try to treat his severe depression, and which helped tremendously. And this led him to actually want to incorporate LSD into AA. And this, of course, like wasn't like handled well by AA members because they felt like it's not right to use an illicit substance if they just try to quit another substance. But this actually led to an interesting parallel in the modern day that we're starting to see psychedelics as useful for addiction. Um, and so this includes a study using psilocybin for alcohol use disorder right here at NYU Center for Psychedelic Medicine by our own Dr. Bogenschutz. And we're going to talk about psychedelics in its own dedicated lecture. But just briefly, psychedelics are basically 5-HT2A receptor agonists. And these receptors are densely expressed along the default mode network and are thought to set to, and it could potentially transiently inhibit the default mode network and induce this neuroplastic state and ensuing this like network plastic state. Um, Along with leading to a real shakeup of rigid self-concepts and improved access to emotions and autobiographical insight, but also reduced defensiveness and shame, along with improved trait openness and a felt sense of connection with other people, people, their own values and purpose. And so there's an additional benefit. The psychedelics tend to reopen critical periods of plasticity, also dendrogenesis as well over several weeks, depending on the drug. And this is all thought to pair really, really well with therapy. And so there's been some early and modern, just very modern studies that are ongoing that suggested efficacy of psychedelic assisted psychotherapy with tobacco use disorder, alcohol use disorder, and also some very early data for opioids and stimulant use disorder. Um, and so there's a lot to say here, but and there's a lot of controversy as well. But it's an ongoing process, and we're still likely, unfortunately, far from FDA approval. But there's a lot of promising data, and there's different agents in the mix too. Like one interesting one that's pretty unique is an alkaloid named ibogaine. This is actually a shrub called Tabernanthe iboga from West Africa, and it's first indigenous use was by the Bwiti tribe in West Africa for spiritual purposes. Um, and this shrub or this alkaloid works in a very unique way. It stimulates kappa and mu opioid receptors, along with modulating NMDA and dopamine. And it's actually been shown to lead to rapid reduction in opioid withdrawal, along with decreased craving across multiple different substances. And there's some ibogaine centers in Canada and Mexico, but it's a Schedule One substance here in the U.S. And also super far, probably far from FDA approval. And there's good reason for it. There's possible neurotoxic and definitely serious cardiotoxic side effects, and so it warrants medical monitoring. And there's some less cardiotoxic alternatives in the mix as well too. So a lot to look into it. There's actually a lot more notes on this if you're interested in reading. But just to close off, in summary, substance use disorders involve dysregulation of three systems, aka the Coop-Volkow model. This is reward, which is stage one, stress, which is stage 2, and executive control, which is stage 3, which you see in this nice little diagram here on the right. Chronic use rewires the brain, which leads to a decrease in dopaminergic function, increased stress signaling, and decreased prefrontal control, which is basically just that's those three systems reiterated. All of this leads to the phenotype of a functional frontal lobe syndrome, which is and this is conditioned over time, but first by positive reinforcement, then by negative reinforcement, and characterized by behaviors of cue-induced compulsive use. And keeping all this in mind, it's really important that effective treatment is multimodal. It involves medications to stabilize reward and stress systems, but also psychotherapy to recondition learning and help restore control. Psychedelics may also help intervene at each stage of the Kuban-Volkel model, but further research is definitely needed, and we'll cover that at a future time. Finally, it's important to know just how so many psychiatric disorders can be, quote unquote, substance induced by making, note of all these parallels and circuits and whatnot. It really helps us better understand psychiatric disorders, but also helps us better understand the vulnerabilities that our patients have and how we can best direct treatment and even sequence treatment to help with addiction ultimately. Um, and so that is it. These are my references. Thank you. And there's some review questions here.